Okay, so now we can start our session. I again welcome you all and to this, amazing journey. And we are back with the session number three, of course. And we already complete lots of things, right? So far, lots of things we already discussed. Let's just recap and then we'll proceed with the session number three, okay? So, in the session number one, we explored the what and why of deprescribing. Okay. And in the session number two, we were discussing about the pathophysiology and the basics of the understanding of deprescribing and management of polypharmacy, right? Also, we understood about how aging and chronic conditions change the way our medicines are, working into the body. So that pharmacokinetics and dynamic parameters we understood in the last session. So today, what's coming? So basically, today we are rolling up our sleeves and getting practical, basically. And this session is all about becoming detectives, like spotting. Okay. We all know how polypharmacy arise, in what case polypharmacy is observed, and what is the frequency of polypharmacy, in what cases you will found, right? So what is there in the session, so it is basically becoming detectives, like spotting those sneaky inappropriate medications that can quietly do more harm than the good. So, for today's session, we will work with the tools, like we'll understand Beer's criteria, stop and start criteria, and the med stopper, how it is working, okay, and how we can implement these particular tools of deprescribing, or we can say polypharmacy management tools, in the practical way. Okay, so we will sharpen our eyes for the red flags also, for the drugs that are very risky, and those combination of the drugs which are very risky in the prescriptions, we'll see that how to identify those combinations. And also I would like to say that we are not just going to make a list and call it a day, okay? No, we will also learn how to perform medication reconciliation. I think in previous lecture we have discussed about medication reconciliation a little bit. Okay, so I briefly introduce the term to you, that what is medication reconciliation. It is also a technique, okay, of the very first point of doing a deprescribing. So we'll see that how to do or how to perform this medication reconciliation, and even will also understand how to run a brown bag review. Now, maybe many of you might be not aware of this term, brown bag. Okay, that is very new, very trendy, and also we can say it is way more interesting to learn the brown bag review. Okay, the term itself, it is very unique. We'll see what it is. Medication reconciliation, brown bag review, where the patients literally bring all their medications, sometimes with a few surprises also come from the back of the kitchen drawer. So that is a brown bag review, right? We'll understand one by one in the PPT. So this is the whole summary of the session. Okay, I also want to advise you that once we have identified the trouble markers, and we will build also the stepwise deprescribing plan together. So has I also have the case studies with me today to discuss. So once we identify the trouble markers in the case, we'll build a stepwise deprescribing plan further. Okay. One that is very patient centered, rooted in the shared decision making, so that our patient feels safe and supported every step of the way. Okay. And by the end of this session, you won't just know what to deprescribe, but also you will know how to do it in a real life, in a practical scenarios. Okay, so I have lots of case studies to share with you. I included three of them, very basic three, and I will ask you to solve this. Okay, and I hope that by end of this you will be gaining the knowledge of Beer's criteria, the fundamental things behind Beer's criteria, the theory, the practical scenarios, how to implement, how to check, what is stop and start criteria, how to exactly use it into the daily practices. Okay, but stopper kya hai, kaise use karte hai, that all things will going to cover. So that is more about practical scenarios rather than theory. So that is the learning objectives, guys, for today's session. And now I'm going to share my screen with all of you. And I want you to give a reminder that you can ask questions at the end of the session. Also, you can unmute yourself and talk, okay? But after the session. So please make notes also, guys, because at the end of the whole course, you will be having small MCQ test, and some passing criteria is also there to get in order to get the certificate. Okay, so do not forget to make some notes and revise everything, because it is a third session. I have to remind you that this is the way. Okay, this is the way, and it is also in the brochure that you will be having exam, you will be having a short assignment as well from the next week. Okay, so please remember to attend every lecture, every class, so you do not miss the notification. Okay. Okay, so I'm sharing the screen. Is visible. Okay, we are back with title Deprescribing and Medication Management, or Deprescribing Techniques, Polypharmacy Management, you can say. And we are back with our third number session, which is the title itself is Identifying Inappropriate Medications. So just imagine you are looking into the prescription, okay? The comorbid conditions are there, the polypharmacy is there, and now you want to identify which medicine is inappropriate. Now that is exactly the session is all about, okay? So basically, see, for now, many students I have observed during my experience, many students are not able to identify inappropriate medicines. Okay, they can suggest, but already some of the indications are there for which the medicine is basically prescribed. So that is very crucial. This is actually a skill. Okay, today we are going to cover 2%, I can say, only a 2% of the whole concept, because that is exactly the theory of identifying inappropriate medication. So I will give you today the idea how to solve prescription queries, right? If you are looking into the prescription, if it is a polypharmacy case, how to identify the medications which are inappropriate in a proper way. I can say it is a skill rather than a theory. Okay, one person can have the whole idea of theory but cannot implement in the practical scenarios, while others are doing it, on a daily basis, identifying inappropriate medicines, eliminating it, suggesting physician to eliminate, to omit, to further add some other combination, right? So this is the skill. Okay, it is not theory. And today we are going to discuss about only 2%, because I will be delivering the Beers criteria theory, okay, and the start criteria, the mat stopper. But once you are practically implementing this theory into your daily practice, that's what exactly the meaning of the course is. Okay, so this is a gentle reminder. Okay, so what are the learning objectives, guys? So by the end of this session, learners should be able to use particularly the Beers criteria, stop and start criteria, med stopper, to identify potentially inappropriate medications, also known as PIMS in a short way, in older adults. Okay, so you should be able to use these criterias in your daily practice. That is my learning objective. Second is you should be also able to recognize the red flag drugs, okay, which are dangerous. These combinations are dangerous in older adults. These combinations are dangerous in some of the conditions which cannot be, go simultaneously. This should be known by you, recognized by you. Okay, so you should be able to understand drugs, drug classes like that, which are linked with the, falls, delirium, hypoglycemia, bleeding, renal injury, and QT prolongation. Maybe you will be having a thought of some classes of the drugs in your mind while I, read this. So, what are the agents associated with risk of falls? Okay, what are the agents in bleeding? So, warfarin, heparin, you should be able to understand that in what condition start criteria. Okay. Also, learners should be able to perform a structured medication reconciliation and a brown bag review. Now, that two terms are very, very important. Please focus on the word medication reconciliation and a brown bag review. Okay, these two terms we will be going to discuss, and you will be able to perform structured medication reconciliation and brown bag review by the end of this session. And also, the learner should be able to build a step-wise deprescribing plan with patient-centered goal, shared decision making, and monitoring. So those are our basically learning objective behind this session called identifying inappropriate medications. I hope learning objectives is clear, because it should be clear in your mind, because it gives you a reason behind jumping to this session. Okay, so that must be understood by you, that what are the objectives, what are the aim of the session. Okay, that makes you more curious to understand why we are learning this theory. So let's start with the very first step and first theory to understand of deprescribing, and that is a framework. Now, this is what I was talking about, the theory. Okay, now this gives you a six step in which you can follow this six steps, and you can de-prescribe a particular prescription. Okay, basically you can eliminate unwanted or inappropriate medications if you found. But what are the six steps? So this is called a framework, a workflow. Okay, let's understand one by one. The very first thing is assemble a complete medication list. Now, here the word complete is very important. Assemble a complete medication list. If the patient is having any of the medicine which are officially prescribed by the physician on a prescription, that is RX, if the patient is taking any kind of OTC, over the counter drug, or any kind of herbal medicine, or any kind of PRN medicines. What do you mean by the PRN? PRN medicines are one that patients, doesn't take on a fixed schedule, we can say, but only when the symptoms arise. So as needed. Okay. Or any kind of topical, because if the patient is suffering from any kind of skin condition, so maybe the corticosteroids or any kind of things are there for the topical, you need to collect that also, and some of the supplements, maybe of vitamins or any kind of things. So, assemble a complete medication list, not only prescription, but other than that also. What is the next step? Let's understand. Align with the goal of care and life expectancy. You should follow 5ms. What do you mean by the 5ms? 5ms is very important for geriatric care. So let me just give you a brief overview of 5ms, because it is not our part of our right now, not a part of our discussion, but let me just give you the brief overview. So this 5ms is basically helping clinicians to focus on what actually matters, most for the older adults, and guide further the medication decision. 5M include medications, mind, mobility, multi-complexity, and matters most thing. Okay, we'll discuss in upcoming lecture what it is. Don't worry if you don't know. That is completely fine. But just understand that first M is for medication. Second is a mind that deals with the cognitive health. Mobility, third, that is the main function, and it prevents falls and everything else. Multi complexity, that manage multiple chronic conditions, social factors, and everything else. Also, the fifth one is a matters most, meaning that is aligning care with the patient's personal values, preferences, and the life goals, quality of life, we can say. Okay, so इसमें सब कुछ आ गया, right? It covers almost everything. That is a 5ms, and that is for geriatric care. So whatever your first step is to assemble the complete medication list, and whatever you have, you need to align that with the goal of care. What is my goal of care? Reducing symptom, increase quality, improving quality of life. What is my goal? And is this the medicine that is aligning with my goal of care of, or we can say life expectancy, whether it is aligning with the 5ms concept or a smart goals. Smart goal is also another tool, guys, and that is also a goal setting method. We can say smart goals is nothing but a goal setting method to make the plans very clear, and we can say you can, measure it. So S is for specific. S word stands for specific, clear and well defined, we can say. Okay. So we can say smart agar plan kar rahe hai, that meanings reduce nighttime falls. That is my goal. So S is specific goal. Okay. M is measurable. Measurable, that means you can track the progress. Okay. So for example, if you are writing from 3 bottles per month, so that is measurable. You are, measuring. That is M. A is achievable. Achievable means realistic. Realistic for the patient situation. R is relevant. That is directly supports what matters the most to the patient. And T is a time bound. Time bound means has a timeline. Like for example, within 3 months. Okay, so it gives you the idea, it gives you the we can say जैसे to do list बनाते हैं, that exactly the smart goal is. Okay, so you need to align whatever medicines you are collecting from a patient, whether it is OTC, herbal, PRN, topical supplements, any of the medicines, and you need to align with the goals of care and the life expectancy. That is a second step of deprescribing. Third step, now you need to assess each drug. Now you have a whole complete list with you, and now you need to assess each drug. What is the current indication? क्यों दिया गया है? Time to benefit versus time to harm. Okay, so in this particular, we can say line, time to benefit versus time to harm, you need to check that whether I need to discontinue medicine from the chart. Do I need to suggest the clinicians that we can switch to the alternatives? Okay, this is very important. Time to benefit versus time to harm. Because initially patient may need, but after some time you may discontinue. Okay. Third, Beers stop start flags you need to understand. That is our second topic to understand. Tools. We'll understand what is Beers criteria, stop and start criteria, what are red flags. Okay, organ function you need to check from the laboratory investigation. Okay, you need to check serum creatinine, or you need to check potassium level, etc., etc., right? And other potent interactions, you need to check. So that is the three steps. First, assess, then align with the goal of care, assess each drug whether it is necessary or not, and what are the other steps. Now see, now these are another three steps. And the fourth one is identifying candidates for deprescribing. So when you are, collecting medicines from the patient, then aligning with the care and the plan, and then assessing the list, now you will be having the idea in your mind clear that whether this candidate is fit into the deprescribing category or not, whether I should perform deprescribing or not. Okay. If yes, then the fifth step will be there. That is a plan to taper, stop, or switch. Whether you need to decrease dose, whether you need to stop or switch to the alternate agent. Plus, safety nets should be there because you are discontinuing, you are switching medicines to one another. You need to what? You need to monitor everything. So you need to have that idea also that what to monitor if I am discontinuing a particular agent, and if or I can say if I am switching to the alternative agent, what needs to be monitored. Okay, if CBC, in particular CBC, what needs to be monitored, and when to call for emergency. Okay, so that is very important. Plan is a very important factor. Okay, and the last step, sixth, is follow up and document. Okay, good documentation practice is also mandatory thing in this particular theory. Okay, so you need to review at 2 to 4 weeks and reinforce non-drug alternatives as well. So this is the whole deprescribing workflow, or we can say a framework, which gives you a basic idea that how to go. But let me tell you, this sentences has so much of gap between these two lines, right? So after having the collection of the drugs with you, after aligning it with the care, and after assessing it, still at three steps are very easy, but jumping towards the fourth one is very hard, like identifying the candidates for prescribing. And if yes, if the patient is fit into the category, then what? Then the plan has their, okay, plan has their role. And this is very important when the healthcare worker like us needs to be have needs to have the therapeutic ecology, pathophysiology, the concepts very clear in your head. Then you can proceed with the plan of tapering, stopping, or switching with the safety nets. So this is very easy and easy to write, easy to understand. But when it comes to the practical way, the scenario is completely different. Put yourself into the situation and imagine that whether I am capable, am I capable of doing it, right? So that is very important. So again, this is a theory just for your understanding. So I am just briefing you. Assemble a complete medication list is the first step. Include all prescription, OTC, herbal, supplement as needed, or else topicals or inhalers, eye ear drops. Verify actual use, what the patient is truly taking, not just what's on the prescription. Okay, that is very important line. Second, align with goals of care and life expectancies. Discuss patient priorities using the 5 M's of integrated care. Mind, mobility, medication, multi-complexity matters the most. I already explained you. Set the SMART goal, specific, measurable, achievable, relevant, and time-bound goals. Okay. And factor in prognosis and quality of life consideration is must. Third point, assess each medication. Check the current indication. Is it still needed? I already explained this theory. Then weigh time to benefit versus time to harm. I will show you in the next upcoming lectures that how to measure time to benefit versus time to harm. Also flag some risk using Beer's criteria, stop start, and the med stopper. We'll understand in upcoming slides. In today's session only, what are they? Okay. What is the first point? To identify candidates for deprescribing. Look for there is no current indication. Look for some high risk of ADRs. Look for therapeutic duplication, drug or drug disease interaction, medications not aligned with the goals of care. Then you can proceed for deprescribing. Okay. The fifth one is create a stepwise patient-centered plan. Involve the patient and caregivers in a shared decision making. Taper the gradually if needed. Avoid withdrawal or a rebound because it gives you a some unwanted or some unintended effect which cannot be solved later. So avoid withdrawal, but you can go for tapering. Okay. Then choose one medication or a group at a time to deprescribe. And last is a monitor, review, and adjust. Track for the symptom changes, withdrawal effects, improvement in function or quality of life, and adjust the plan as needed and repeat the cycle for other patients. Okay, that is the complete theory of deprescribing. Sounds very good, right? But when you are implementing it, that is the complicated, right? So we'll see that how to perform it, and my aim is that by end of this course you will be able to do it. Okay, so do not worry. Let's start. Okay, so now second point. Sorry. Okay, so the first point was all about the framework, how to start, how to end the deprescribing in a general way. Now, second is the tools. So, in the the fifth point of deprescribing was planning, and planning requires what tools? What are the medicines to be stopped? What are the medicines to be omitted from the prescription? So that requires what tools. So the second topic of our session is tool understanding. And the very first tool in the deprescribing and the polypharmacy management is Beer's criteria. Okay. And I think in previous lecture, we had some discussion on Beer's criteria and one good video also that was showing how to use it. Actually, it gives you the idea, it gives you the red flags, it gives you the combination that needs to be avoided in the geriatric population to reduce toxicity. Okay. So let's start. Basically, Beer's criteria is I already included the timeline also in the next slide. While the AGS, that is the American Geriatric Society, has published. So we'll see. Let's understand first basically what it is. So basically, Beer's criteria is nothing but a list of drugs. Okay, list of medications or drugs which are potentially inappropriate in the older adults. Do not use, or if still you want to use, you should be having the monitoring with you. Okay, sincere monitoring is required. So list of drugs potentially inappropriate in the older adults category, and that includes what? Complete avoid or avoid certain diseases or syndromes, or use with caution, or clinically important interaction categories in it. So imagine if the If one of the class we can take, for example, benzodiazepines. So in Beer's criteria, benzodiazepines has which category? Avoid, avoid in certain condition, use with caution, or clinically important interactions. That is how exactly the Beer's criteria is, defined. Okay. For example, let's take atorvastatin. Okay. So you can avoid, or you avoid with certain, in the certain disease, use with caution. So atorvastatin will fall under the category of use with caution. Okay. So that is how the Beer's criteria is defining all of the classes of the drugs into particular categories, so that you can have idea what to avoid in geriatric care. Okay. Bear criteria for older adults are very important for understanding of anticholinergic meds. So we'll understand as in the next slides what are the potentially inappropriate anticholinergic meds which cannot be recommended in geriatric care. Okay, so that is all about Beer's criteria. Let's explore the timeline for our basic understanding that then and now the difference of Beer's criteria. So, Archives of Internal Medicine, what it indicates. It started from 1991. First published criteria for inappropriate medication use in the nursing home setting was from 1991. Then in 1997, persons 65 years and older, regardless of their level of frailty. I hope now you know the meaning of frailty. Frailty, last lecture we discussed, right? That is a weakness. Okay. In short term, we can say weakness. Okay. So level of frailty of their place of residence. That is 1997, the timeline. In 2003, ambulatory and nursing facility population 65 years and older came into the picture. What do you mean by ambulatory patient? Ambulatory patient means someone who can walk around on their own, okay, not bedridden, we can say. So that for those patients, the Beers criteria, that facility is also available for the population of 65 years and older for the Beers criteria perspective, 2003. Okay, and Journal of Aging that started from 2012. So all ambulatory and institutional setting of care for population of 65 years and older was the criteria for 2012. 2015 to 2023, the same situation is there, like adults 65 years and older in all ambulatory care, acute and institutionalized setting of care, except for the hospice and the palliative care settings. उसके ज़्यादा सब जगह पे the Beers criteria is prominent. Okay, it is under use. So this is how the evolution of Beer's criteria taken place. For this is for basic understanding, nothing to remember from this slide, but we just need to understand that it started from 1991, and for the current version, the current scenario is completely different. Majority of the hospitals are using these things. Okay. How to use Beer's criteria? Very first thing, the criteria suggests to identifying age greater than 65 years of age. So basically, Beer criteria is more important in the geriatric care setting. Okay, so you need to identify your patient's age first of all, that it should be greater than 65 years. Okay. Second, screen the list for Beer's drug. As I earlier said, that Beer's criteria has a list of drugs and the different categories to avoid, or you can use with caution, etc. You need to screen. Okay. Third is check the disease based caution. Okay, so you need to check that your patient are having any kind of comorbid conditions or not. If yes, what are the pills for that and the interactions. Okay. Fourth, consider the appropriate dose, appropriate route, and the renal function, because 95% of the drugs, as we earlier session, we already discussed about pharmacokinetics, right? And we understood that majority of drugs are excreted from the renal route. So you need to check renal function before prescribing or before deprescribing as well. And weigh alternatives. Understand what are the alternatives you are already having. Okay. See, this is the picture to understand Beer's criteria in more detail. This is how exactly looks like. Potentially harmful, Beer's list, and more. So this is only for your understanding. I have kept this in the slide. You can see here some of the analgesics listed first of all, and then antidepressants are there. amitriptyline and the doxepin, and analgesics are also there. And see, the concern is also written like in geriatric care, if you are using some of the analgesics, it may give you GI bleeding. Alternate option also suggested here that short acting NSAIDs you can go for mild pain. If the pain is moderate to severe, don't go for this analgesic. Instead, you can switch to the another agents. So this is how the Beer criteria has list of n number of agents. Okay, so Beer criteria is nothing but a list of drugs. List of drug with the concern with the alternative treatment options. So you just need to go search and check the disease based causal, consider the appropriate route, and make alternatives. This is how the Beer criteria is theoretically understandable, right? So in next upcoming slides, I am also having the case to discuss and to understand Beer criteria in more detail. Don't worry, this is only for your example. Okay. Okay, what are the high yield beer example we are having? First, as I earlier said, I also has that picture in the slide, anticholinergics. Any kind of amitriptyline and anticholinergics like the amitriptyline, imipramine, hydroxin, and the diphenhydramine that leads to confusion, constipation, urinary retention, and fall episode. See, this is all about geriatric population. So please remember in that way and understand that way. Okay, it leads to confusion, constipation, urinary retention, and fall episode. Anticholinergics. For that, you need to check Beer criteria. If the patient is having greater than 65 years of age and using benzodiazepine or any kind of, the Z drugs, that is the Z hypnotics, basically, diazepam, midazolam, alprazolam, or Valium, okay, any kind of these agents, if the a patient is using, you need to understand. See, Z drugs are nothing but the non-benzodiazepine sedative hypnotics. Okay, for your understanding, I'm elaborating the terms. For that also, you need to check what Beer's criteria. Okay. Third, we are having it. See the antipsychotics for the BPSD. Now, BPSD stands for Behavioral and Psychological Symptoms of Dementia. If you don't know, please see in the bracket behavioral and psychological symptoms of dementia. So, if the antipsychotics are used for BPSD, the high risk of stroke, mortality, okay, risk is there. Restrict to severe distress or danger after non drug measures fail. So, that is very important to monitor if you are using any kind of antipsychotics in the geriatric population for dementia management. Okay. Fourth is NSAIDs, that is a non-selective, which is in the CKD if you are using, or any kind of heart failure case if you are using, with the combination of ACE or ARB plus diuretics, which known as a triple whammy effect. If you don't know, this is very important. Okay. So if NSAID is going with any kind of ACE, ARB plus diuretic, so there is a triple combination. Three drugs are there: non-selective NSAIDs, ACRB, or diuretics. Okay, so this three called as triple whammy that leads to major injury, AKI, and the GI bleeding risk. If you found this particular thing in your prescription, you can clearly go for Beer criteria. Okay, it will give you some alternate agents. Majority क्या होती है कि many of time this three of the agent you will never find in the prescription. Okay, very rare case if you found ARB, diuretic, and non-selective NSAID also. Okay, so some very clear indication is required before prescribing this triple whammy because it is associated with the AKI and GI bleeding. These are some of the high yield beer example. Next, we have sliding scale insulin alone. As I earlier said, it gives you a major risk of hypoglycemic episode, right? Risk without improved control. So that is again need to check in the beers. Sulfonylurea, for example, glyburide or glibeclamide, that is giving you a prolonged hypoglycemia as well. Meperidine, skeletal muscle relaxant, and first generation antihistamines. Again, increase the risk of CNS adverse effects. And digoxin, very popular drug, greater than 0.125 mg per day in the heart failure and the CKD patient, gives you a major toxicity as well. So these are some of the high yield beers example in which this criteria must be followed. Okay. Why I have kept the slides inside this presentation? Because of your understanding. Okay, कि in which situation, what are the situation in which Beer's criteria needs to be followed? These are some of the high yield examples. Okay, I hope it is clear. Now, the second tool to understand after Beer's criteria is a stop and start criteria, which is Europe origin, and it is a way more practical as compared to Beer's. But simultaneously they both can work together. Stop and start and Beer's. What is stop? As its name suggests, you can see here, as its name suggests, stop is screening tool designed for the older person's prescriptions. What to stop and what to avoid. That gives you the idea, the stop criteria. Okay. And what is start? Again, it is a screening tool to alert to the right treatment, like what to start when it is indicated. Okay. So basically, you can say, I already explained you the re-challenge and de-challenge in the previous lecture, right? In the ADR form, that must be, filled, re-challenge, de-challenge. So you can relate this criteria with that particular concept. Stop and start. Okay. When to stop, when to start. Why it is useful? Because it adds indication based flex. Okay, why you are doing it? Why is very strong behind stop and start criteria. Okay, so it is an indication based flex, and disease specific logic also it gives. So basically, it complements beer. As I earlier said in the starting of the stop and start theory, that simultaneously it makes a better pair. If you are going with the beer's criteria and checking stop and start criteria as well. So I hope now you know that what exactly Beer's criteria क्या suggest करता है, and if once you found that what are the agents that needs to be avoided in the geriatric population and the alternate agent, then you can go for this. Okay, it complements the Beer criteria. Stop and start. Okay, let's understand what is inside it. Okay, so typical stop hits क्या है? So if see here, the examples are given here because this is very basic and very raw. So I have kept lots of examples to understand what is a typical stop hits. Okay, so first scenario is a long-term benzodiazepine for greater than 4 weeks in the older adults. Now the risk behind this benzodiazepine use is very very high. In this particular thing, stop criteria में अगर आप डालोगे that your patient is taking benzodiazepine for more than 4 weeks and the age is 82, then it will suggest you stop immediately. Okay. Or the second example also we are having, see here, tricyclic antidepressant, TCAS, tricyclic antidepressants. For examples, amitriptyline or imipramine, nortriptyline, etc. The tricyclic antidepressants in patient with dementia, very common treatment, or glaucoma or constipation or processism or other anticholinergics. That is also giving you a signal if it is using for more than the required timeline, that the stop criteria will suggest you to immediately stop this and go for alternatives. Or the third option here, the example here is NSAIDs in HTN, hypertension, heart failure, or CKD, duplicate drugs class that is found in the prescription. Okay, that is also needs to be stopped. And proton pump inhibitors at max dose, like greater than 8 weeks maximum dose pay, without high risk indication, that needs to be also stopped immediately. So in this situation, the stop criteria will help. And what basically start hits? So avoid AC and IV in the systolic heart failure or diabetic nephropathy unless it is contraindicated. If it is, then stop. If not, go for it. So that is a start hit. Okay. Blocker post MI. So post myocardial infarction, beta blocker should be there. That gives you the idea. If you are following the prescription, if it is not there, then and you are inserting the whole mechanism, the whole case study in the criteria, it will suggest you to go for beta blocker if it is a post MI treatment. Okay. Anticoagulants for atrial fibrillation. AF here is atrial fibrillation. Anticoagulation for atrial fibrillation with a particular chemical moiety gives you a balanced bleeding risk. There will be no bleeding at all and also anticoagulant effect. Okay. Also with the vitamin D with calcium in the housebound or the recurrent fallers. Osteoporosis wale case mein is where the diet is insufficient, very insufficient. That is very common case. In that, vitamin D plus calcium is there. So that is a start hit. Okay. So this stop hit basically gives you the signal of what to start and what to stop in a particular prescription. But let me tell you that we cannot completely rely on Beer's criteria and stop and start. We need to have a very basic and very deep knowledge, concept clarity of therapeutics, pharmacology, also toxicology and pathophysiological things, right, clear in our head before jumping into this. These are our plus point, we can say, but we cannot completely rely on these things. You might be having thinking that what is the need of studying if we are having this tools with us. Direct prescription enter karo. It will suggest what to stop, what to start, and what are the alternate agents as well. But practically, I will share some of the cases with you as well in which this criteria, has failure risk as well. So we need to have knowledge plus using of these tools in appropriate way. Okay. Now the third tool is Med Stopper. The name itself, the meaning it is having Med Stopper. Okay, medicine stop. Decision aid के लिए बहुत important चीज है. What it does, so it ranks the meds. It gives you the ranking to the medicines by estimated likelihood of harm versus benefit in older adults. So that is very simple to understand. It will give you the rank like benzodiazepine. So it will give it a rank. So if it is 1, you can go for it. If it is 5, you cannot go for it. Vice versa, right? In order, it is giving you the suggestion of deprescribing order, tapering schedules, and withdrawal recurrence symptoms to watch for. This is very, very important. Med stopper. Okay. Software it is. Why it's useful? Because it adds again indication based flex and disease specific logic. Again, it is same like the stop and start criteria. It is complementing the Beers criteria. These three things go simultaneously. So I hope you now understand that what are the Beers criteria, stop start criteria, and med stopper does. Okay. How to use in clinic? Again, enter the current meds. Med stopper को कैसे use करते हैं? It is a software basically. So you just need to install and you need to access it. Okay. Enter current meds. Review the color coded benefit harm bars. It will give you the red, green, blue colors. Discuss with patient. Print the plan and monitor the checklist. Right. The goal here is use it to sequence deprescribing, like to stop the diphenhydramine if you want before tackling to PPI. Then address benzodiazepine, that is last with the taper. So what does this meaning? ये sentence का मतलब क्या है पता है? This is very important. So if you are using Beer's criteria, stop and start criteria, and med stopper in a single use, that is the meaning of this sentence. So that sentence is basically, describing deprescribing order of priority for a patient on a multiple risky drugs. Let me tell you what is the meaning. Very interesting it is. First is the stopping diphenhydramine first. See, for example, stop diphenhydramine. It is a strong anticholinergic, everyone has idea, and can cause confusion for urinary retention in older adults. Okay, so it's a high priority or we can say a red flag medicine to remove very quickly. So अगर ये मेडिसिन ये प्रिस्क्रिप्शन आप अगर मेड स्टॉपर में या फिर स्टॉप स्टार्ट क्राइटेरिया में इंसर्ट करेंगे, what it will give you? The suggestion of stopping diphenhydramine, okay, quickly. Then tackle the PPI, the second line. Tackling PPI means it is a proton pump inhibitor being used for long term without clear ongoing indication. So it will suggest you to reduce or stop it next. Next. Okay. And the third is address benzodiazepine last with a taper, meaning this required a very slow, careful dose reduction to avoid withdrawal symptoms. So they are left for last and handled gradually. That is the meaning of the whole sentence. So it is basically saying the whole line remove the highest priority risk drug, easiest to stop med first, and then move to the others, saving the most withdrawal prone drug for the last. That is the exact meaning of this particular sentence. Okay. And if you can imagine, this sentence has three criterias: Beers, stop and start, and med stopper as well. Okay. So this is how it is. What is the integration tip here? How to integrate these three rules? Apply beers or a stop to flag the candidate कि कौन से वाले candidate में हमें deprescribing करना है, right? The major point I already addressed while explaining the learning objectives, guys, right? कि fifth point जो है, the very first framework we understood, and the fifth point from the framework, that is a plan, and I already explained you that lines is very broad, right? To identifying this candidate. To identify or the flag the candidate, you can go for what? Beers criteria or a stop criteria. Okay, which is in your hand, like the phone is there, the laptop is there, you just need to search it. And that will flag the candidate that you need to go for deprescribing the particular candidate or a patient. And then go for what? Med stopper to prioritize and taper. Okay, so this is how you can integrate tools in the daily practice. I hope you might be having idea now, and you will be practicing from now that seeing a prescription, going for checking it, check the Beers criteria, stop criteria, and then go for med stoppers. Suggest clinicians to do some changes in the prescription if you found any. But without proper indication, you cannot go forward, right? So please understand theory first. So that is the all about the second part. Now the third point of learning high risk drugs and classes for now, let's understand it. See, some of the syndrome or the risk is there for column. Then the red flag drugs are there. Why risky in older adults? The mechanism is listed here, and safer alternatives are also there. Now these are nothing but listed category of drugs in the Beers criteria. Syndrome you can see here. Some of the red flag drugs like benzodiazepine or a Z drug, I already explained you what is Z drugs. Z drug are non-benzodiazepine. Okay. Or some strong anticholinergics like tricyclic antidepressants or oxybutynin or first generation antihistamines, opioids, any kind of those uh, drugs are having direct association with the falls, fractures, and delirium in geriatric population. What are the safe alternatives? You either go for CBT, okay, cognitive behavior therapy, or some metazapine for insomnia management, weight loss के लिए melatonin, okay, with the weight loss melatonin, non-drug pain strategies, lowest dose of SSRIs or SNRIs you can proceed with, okay. Very good example, mirabegron. Mirabegron is a medicine used for OAB. What is OAB? That is the overactive bladder, okay, overreactive bladder you can say, or overactive bladder, okay. So basically this is a very specific agent you can go for which are safe in the geriatric care. Same goes with the bleeding risk. Warfarin, I already explained you, that is the highest risk. And you can also check the why risky thing, platelet effects, right? So to avoid this kind of things, you can go for the safe alternatives like the PPI, gastroprotective protection when the high risk. Avoid NSAIDs and consider acetaminophen. Okay, and review need for a dual pathway inhibition as well. So same goes with the hypoglycemia. I hope now it is a self-explanatory diagram, okay? Self-explanatory table, I guess. And also this you will be finding on the Beers criteria, these things, okay? For your understanding, I have included so that you have some common understanding today. See here some of the hypoglycemia associated with the glyburide or glibenclamide or insulin. Okay, and you can go for alternatives like relaxed A1C targets and prefer glipizide or DPP4, simplify basal regimens basically. Same goes with the renal injury, QT prolongation, hyponatremia falls, and cognitive decline. These are all associated with the common medicines. You can see SSRI, SNRI, anticholinergic burden. See here, यहाँ पे लिखा हुआ है ACB and ARS. I hope you know this anticholinergic burden phenomena. If not, let me explain. This is very important. This ACB is an anticholinergic cognitive burden scale. Okay, this is a scale to measure anticholinergic burden because anticholinergic drugs are having a potential side effects and geriatric care में बहुत होता है. Okay, so this ACB is a scale that rates your medicine from 0 to 3. 0 to 3. If you are noting it down, very good. Please note it down if you don't know. This is rating medicine from 0 to 3 based on their anticholinergic effect. Like higher the total score, greater the risk of cognitive impairment, confusion, fall, constipation, etc. And often it is used in the dementia care and deprescribing, to identify the high risk burden regimen. तो ये देखा जाता है that if the specific anticholinergic drug falls under which category, 0, 1, 2, 3, higher the total score, greater the risk of cognitive impairment. That is ACB, anticholinergic cognitive burden scale. Same, second we are having ARS. ARS is anticholinergic risk scale. Okay, anticholinergic risk scale. It is also similar idea, but it ranks the drugs by their potential to cause anticholinergic events. Okay, also use 0 to 3 scoring system here in ARS. Total goal has to guide deprescribing patterns and priorities. This is very important, and this is very commonly used in the hospital setting in the long term care. जो patient admitted होता है, right? So these are anticholinergic burden, ACB and ARS. And for that, you can go for switch to non-anticholinergics and deprescribe duplication as well. Okay, so these are some of the high risk combination of drugs you need to check, and some of the skills you need to have in your mind while going on the ward rounds or checking the patient's cases. Okay, see, these are anticholinergic burden tools: ACB, ARS, DBI is also a scale. DBI is a drug burden index. अगर आपको नहीं पता है, please guys note it down. This is very important. I'm again repeating. ACB. ACB is anticholinergic cognitive burden scale. ARS is anticholinergic risk scale. And DBI is a drug burden index. Drug burden index, इसे हम कैसे explain करेंगे? So basically it is, broader term. Drug, यहाँ पे कुछ specific नहीं किया है कि anticholinergic की ही बात हो रही है. Right? Drug burden index is a broader term than the ACB and ARS. It measures the total burden of both anticholinergic and the sedative medicines as well. Okay, so both are measurement is done in the DBI. Basically, this DBI use actual dose plus drug potency in a formula. I will explain you later in upcoming slides, and it is bit more precise, we can say. But higher the DBI score, we can say poorer the physical and the cognitive function of the patient, higher the fall risk and worsen the quality of life. ऐसे explain कर सकता है DBI को, right? So हम क्या एम रखेंगे हमारे स्केल का? ACB, ARS and DBI का स्कोर कैसा होना चाहिए? It should be less than 3, of course. I already explained you. Higher the score, higher the cognitive impairment chances. Okay, so reconcile across the specialties like urology, psychiatric, allergies, often, the stack anticholinergics. You can see here the diagram that are the side effects of using anticholinergics medicines. And the burden is very, very huge. And for that reason, the scales are here. ओके, सो अगर आप देखते हो पेशेंट के प्रिस्क्रिप्शन में दैट इफ द पेशेंट इज हैविंग मोर देन 2 to 3 anticholinergic agents, then this scale, check it, and this will be your case of anticholinergic burden. Okay, and I hope now you also know why this is having so much matter in our course and deprescribing, because this tool is very helpful to quantify our very hidden cognitive and safety risk for a medication list. And it also supports shared decision making because score is there, scale is there. Okay, so very important: ACB, ARS, DBI. Okay, now let's move for the fourth point, and again important point, and that is medication reconciliation and a brown bag review. So let's start with the very first thing. What do you mean by medication reconciliation? I already explained you in the last session, medication reconciliation. You need to check it from the scratch, basically. Okay. So very first thing comes under this medication reconciliation term is a best possible medication history taking, BPMH, best possible medication history. Source क्या हो सकता है? Patient itself, if not caregivers, their pill bottles, MARS, medication administration records, files, right? Medication administration records, pharmacy fill history, previous discharge summaries, maybe of multiple hospital visits, right? So that needs to be your powerful source. And what to verify? Your drug, dose, route, frequency, indication, start and stop date, last fill, adherence. Okay, adherence is very important. For adherence, I hope I already explained you in the last sessions that what is adherence. Adherence means sticking to the guidelines. So if you suggest patient to take medicine for 4 days, and if he or she is taking for 4 days, she or he is adhere to the guidelines, adhere to the prescription. If not, non-adherence. Okay, how to check it? Adherence. Adherence check करने के लिए हमारे पास और एक scale है, which is nothing but Moresky Green. Okay, the Moresky Green 4-item scale, that is often called as the Moresky Medication Adherence Scale. Okay, please understand and remember, this is very important. If you are going for the project also for the 5th year of PharmD or anything else, for adherence check, you can go for this scale, Moresky Green. Okay, Moresky Medication Adherence Scale 4, or it is short form में MMAS लिखा जाता है, MMAS 4. This is nothing but a quick questionnaire that is used to assess how well a patient is sticking to their medication regimen. Basically, okay. It was, I can briefly introduce that it was originally developed by Donald E. Moresky, the name itself, and their colleagues. So from that name, from his name, the scale itself has the meaning Morisky. Okay. So patient needs to answer 4 yes or no questions. Like, do you ever forget to take your medicine? Yes or no. Are you careless at times about taking your medicine? Yes or no. When you feel better, do you sometimes stop taking your medicine when you feel better? Yes or no. Sometime if you feel worse when you take your medicine, do you stop taking it? Yes or no. If patient is saying yes to each of these 4 questions, give them the one point to each. ओके, स्कोर कैसे मेजर करेंगे? इफ 0 आया, पेशेंट ने सब कुछ नो बोला, राइट, देन इट विल बी हायर एडरेंस. इफ 4 आया, इट विल बी लो एडरेंस. Okay, so that is the adherence scale, Morisky Green. Please guys remember, this is very important. And affordability. So this is what patient needs to be taking. For that, second step is a brown bag technique, brown bag review. Step by step, understand, please understand what is brown bag. Brown bag is asking patient or a caregivers to bring all of the meds, as I earlier said, in the framework. Very first thing to do is this, right? Assemble करके word था वहां पे bold में, framework में. That is nothing but ask them to bring all of the meds, whether it is prescription, OTC, herbal, IR, inhaler, topical, injectable, sample packs, expired, whatever it is. If they are taking it, tell them to bring it. Okay, layout by organ system or the problem itself, whatever the chief complaints are. Remove duplicates or expired first of all. For each item, ask them, why are you taking this? Who started it? When? Any benefits, any side effects, etc. Do the patient counseling. Identify further no indication, no benefit, time expired prevention, and drug disease conflicts and the drug-drug interaction. For that, you are also, you are expert to use, to use some tools. We are also using micromedics on our daily life. Go for it, check it, at them what to stop now versus taper versus switch, what it is. Provide a printed, updated list and document the changes. Communicate to the PCP, specialist, community pharmacist, and schedule further the follow-up visit. This is nothing but a complete brown bag technique. So the name is very unique, but the concept is very simple. And you can see here, the brown, we can say now, brown bag technique is the very first step of deprescribing framework. Can we say? Yes, right? Can we say it that a brown bag technique, brown bag review technique is the very first step of deprescribing. We can say assembling, right? And then documenting it. So that is the first step of deprescribing. That is what we can say. In many competitive exam, I found this question, true or false, right? Brown bag technique is the very first step of managing polypharmacy. But if you don't know what is brown bag, it is very simple. The name itself is very unique. Otherwise, the concept is very simple to understand, right? Okay. And what is a quick checklist? Printable checklist should be there. Checklist must be having that boxes in which you can tick. Okay. Indication still valid? No. Yes. No non-drug options tried? Yes. No. Then does appropriate for dose appropriate for EGFR, weight, and hepatic function? Do we calculate interaction checked like CYP3A4, 2D6, PGP, and anticoagulant, antiplatelet stacks? Because some of the agents I already explained you in the last session, pharmacogenomics comes here. Many of the you know 70%, I can say 70 to 75% of the our medicines are gone through this and metabolized by CYP450 enzymes, right? So we check interactions based on that. False cognitive risk, that is maybe that may meds present or not. Then stop and start applied or not, criteria dekha hai ya nahi while assessing a prescription. And patient goals understood and shared decision documented or not. So quick checklist should be also there handy with you. Okay, now we are coming uh, to solve some real world case studies. Interesting it is. Case 1 is the forgetful fall. The profile you can see here, 78. Focus on the age, 78-year-old woman with the diabetes, osteoporosis, early dementia. तीन चीजें हैं उसमें. मेडिसिन देखो यहाँ पे कौन कौन सी है. ग्लिबेनक्लामाइड, then amitriptyline 25 mg at night for the neuropathic pain, vitamin D, then alendronate weekly and PRN chlorphenamine as needed, right? And omeprazole 20 mg daily for greater than 1 year. Omeprazole greater than 1 year. Please see the details. And recent nocturnal fall, EGFR is 58. Here the flags are, Beers क्या दिखाता है criteria? यहाँ पे मैंने ऑलरेडी मेंशन कर दिया है बिकॉज वेरी फर्स्ट टाइम वी आर solving the real world case. From the next lecture I will be telling, asking you to solve it. Okay, what needs to be checked, and we'll also use Beers criteria. Will start we can start the cameras as well, and we can go for some real practical time of using Beers criteria as well. Okay, so यहाँ पे the flags are amitriptyline and the chlorpheniramine, the pheniramine, right? Why it is? Because here for the pain management, that is not compulsory to go for amitriptyline. There are some alternate agents in case of dementia because patient is already 78 years old and early dementia is there. So for that reason, some other option, the pain relief option can be preferable. Okay. For this chlorpheniramine, another agent, alternate agent, Beer criteria suggest. See this, what will be the plan? One is to switch some neuropathy like a gabapentin or some pregabalin, low dose, or duloxetine. That is, obviously, we need to monitor sodium if you are going for that. But yes, we can switch. Replace your glibenclamide, that you can go for glipizide, that is low dose again, or DPP4 inhibitors to relax your A1C target. You can set a target like 7.5 to 8% given dementia, or the fall risk will be less. Taper PPI QOD to stop because greater than 1 year omeprazole. Okay, so you can also taper PPI if no compelling indication is there. Use some H2RA receptor, okay, receptor antagonist, H2 receptor antagonist for antacid category and not PPI. Okay, educate on the sleep hygiene, avoid sedating antihistamines, and consider some of the mirtazapine if the appetite or the weight is low, because these are some of the alternatives. This is nothing but Beer criteria suggestion. And do follow up glucose logs, fall diaries, and cognitive cognition, and reassess in every 2 to 4 weeks that what is the update, right? That is very important. Second case here, the swollen ankles. See the case 82. For today you just need to do a critical thinking. That's all it is, right? You just need to understand what is the case and what is the solution. Okay, I am not asking any kind of answer from you because अभी अभी हमने सब theory किया है, so I don't expect today to grasp it all and give the answer, but from next lecture you need to do it. Okay, so please understand the case. Case B is the swollen ankles. 82, focus on the age, year-old man with hypertension and already having what? The osteoarthritis of the knees. OA knees means osteoarthritis of the knees. CKD stage 3. GEGFR here is 38. Also, heart failure with preserved ejection fracture. I hope ejection fracture का types आपको पता है, right? Heart failure, preserved ejection fraction, meds you can see here, lisinopril, furosemide, ibuprofen, TID for 400 mg, amlodipine 10 mg, aspirin 75 mg, present with again rising creatinine and edema. What are the flags here? NSAIDs in CKD and heart failure. मैंने आगे ही example दिया था high yield Beers criteria examples using NSAID in CKD, right? So NSAIDs in CKD and heart failure patient. Also ACI plus diuretics plus NSAID. इसे क्या बोलते हैं हम? Triple whammy, right? So I already explained you earlier. Here in this case, you can see here ACI is there, diuretic is there, and NSAID is also there. It increase what? AKI risk. And you can see CKD, right? And high dose of amlodipine is also leading to edema. Should be plan instead. Stop NSAID immediately. Okay, analgesia, topical NSAIDs you can go for, acetaminophen, physio you can go for, intra-articular steroid if it is needed, and if the risk versus benefit ratio suggests this. Review blood pressure regularly. Consider lowering amlodipine dose. Add some of the compression salt review you should be taking care of. Monitor some of the serum creatinine, potassium in 1 week. Educate on OTC and SAID avoidance, please. So this is how your plan should look like instead of the case summary. And trust me, in the practical scenarios, this will be there. Okay, and I hope now you know the importance of deprescribing actually. Okay, last case to understand for midnight pills and morning dizziness. Midnight pills and morning dizziness. See, 68-year-old with the chronic insomnia and the GAD is there, generalized anxiety disorder. Generalized anxiety disorder. Medicines are zolpidem 10 mg nightly for 1 year, alprazolam 0.5 mg PRN, sertraline 50 mg, two recent fall already observed. Now, flags here are the Z drugs plus benzo. Now, Z drugs are what? Are a group of medicine, non-benzodiazepines, right? Also, it is a category of sedative hypnotics. And insomnia के लिए बहुत बार use होता है. But combining these two leads to fall. So, plan क्या होना चाहिए? Share decision. Like start some of the CBT, cognitive behavior therapy, phase 1 say, taper your dose, zolpidem, by 25% every 1 to 2 weeks. Reserve your alprazolam for severe panic condition only. Consider non-sedative anxiety strategies or use some alternatives like the buspirone. Also provide some sleep routine handout, schedule follow-up in 2 weeks. You can see here Z and benzo goes simultaneously leads to the fall and delirium risk. Okay, so this is midnight pills and morning dizziness case. I hope now you have idea that how to go with the profile, how to check plan and how to solve it. Okay, here is a quick quiz guys for you. Mr. Sharma is here, 82 is the age with the CKD stage 4. Here is the prescription, metformin, simvastatin, multivitamins and lorazepam. Now, tell me which medication is the most urgent candidate for deprescribing here. Okay, I think there is one question. There was one question during the session. Let me just. Okay, what is sliding scale insulin? Okay, see, this SSI, that is the sliding scale insulin, is a dosing method basically. Dosing method, we can say, where the amount of, short acting or rapid acting insulin given, which is based on patient's current blood glucose level at the time of testing. Usually it is, before meals and at the bedtime. So there is a calculation behind it. So the care team sets a scale or a chart for this sliding scale. Lower the glucose, little or, no insulin is required. Higher the glucose and the more insulin is required. Okay, no questions. Ma'am, kindly share the recording. Yes, yes, I will share. I will share. The team will share actually. You didn't receive last lecture's recording. Okay, I will forward your request to the team. Any question, guys? No? Oh, okay, all right, everyone, let's wrap up for the today. So, we already, I just giving you a gentle reminder that we have covered a lot of things. So, from like today, from stopping inappropriate medicines with beers, stop and start, med stopper to reconciliation, red flag drugs, etc., brown bag review, and most importantly, we have talked about turning all that detective work into a stepwise deprescribing plan. Okay, that's very safe, patient centered, and that shared that decision making. So remember, please, deprescribing isn't just about cutting the pills. It's about improving whole quality of life. And make sure further that every medicine on that list of your prescription on your hand has a very clear reason to be there. Okay, so for our next session, we are going to take this one step further. We will go and applying these tools and principles to the real patient cases. Okay, where the decisions aren't always black and white, basically. So that's where your clinical judgment, your teamwork, communication skills will really come into the play. So that is the end of the session three. But please understand that we are moving further with the very practical session four. You will be having a recorded session. PPTs are, I think, that is not in our, uh, that not in our protocols. Okay, guys, great work for today. I will see you next time, next Wednesday. Thank you for joining. Thank you. Thank you so much.